Perfect.
That work?
Yeah, perfectly, Mike. I see you
All right.
loud and clear.
Want to see the view from my window?
Yeah, I do. Wow, it's beautiful today. Oh my goodness, who would have guessed that's Pittsburgh?
70 degrees
Unbelievable.
and snow on Friday.
Oh, that's amazing. That's just the ski resorts up north, my kids tell me, are suffering horribly.
Oh, there's nothing here in Pennsylvania. We have a ski slope about an hour and 15 minutes from Pittsburgh. It's bone dry.
Yeah, son of a gun.
How about the ski slopes down there in Naples?
They're good. It's all water skiing. We do all right. It's a beautiful day here, I have to say. It's in the low to mid 70s and just gorgeous. Yeah, you got to come down again.
I will. Next year, we already made our reservations. So we finally will be in your neck of the woods in probably the first or second week of January.
Oh, beautiful, beautiful, beautiful. All right. David, you let us know when to.
We're ready to roll.
Okay. All right. Well, great. Hi, I'm Dr. John Ventura, the Director of Education for Spine Care Partners and the Primary Spine Provider Network. I want to welcome you all today to our masterclass series. Today, we're going to be interviewing Dr. Michael Schneider, who holds both DC and PhD degrees and is currently a faculty member and researcher at the University of Pittsburgh. Mike, I thought we'd take the first few minutes and ask you to just tell us a little bit about your background. How did you end up at UPitt?
Yeah, so I practiced here for about 25 years in Pittsburgh, and I knew a lot of people at the university. I was always teaching a lot of postgraduate courses, et cetera. Always had sort of a armchair, researcher mentality, and decided I'd go back get my PhD here. So when I was getting my PhD in rehabilitation science at Pitt, I got my first NIH grant, and that just landed me a job right away. And I've been very fortunate since then, for the past 15 years, of continually getting federal funding for lots of clinical research trials.
Yeah. Is it still publish or perish mentality in academia? That's historically what we had always heard about it.
Yeah, one of the major differences between working here at a major university like Pitt and any chiropractic college, not to demean the chiropractic colleges by any means, but the faculty review that I go through every year here, is so comprehensive compared to what chiropractic faculty members go through. So I have to sit down with my department chair, and to your point, they want a list of my publications.
Yeah.
Right? How many platform presentations have I done at what scientific conferences? That's done every single year. Okay. And if you're not publishing, your department chair is going to look at you and say, "What's going on here, dude? Do you want your contract renewed or not?" I mean, they're very serious about it.
Yeah, I understand. How's your time allocated? How much are you spending in research versus how much are you spending as a faculty member?
Yeah, so, I guess a better way to put that is how much time do I devote to research versus teaching and service, right? Those are the three main, I would say I'm 90% research. Okay. I don't have any primary teaching responsibilities.
Okay.
I have some service responsibilities. I serve on the IRB, I mentor PhD students, but yeah, 80-90% of my time is research.
Okay, great.
Again, a luxury that most chiropractic faculty don't have.
Yeah,
absolutely. They got to teach at least 50% of their time, if not more. And then they're expected to do scholarly activities. It's impossible.
Yeah.
And you can see that the productivity is low. The research productivity is low in chiropractic schools for that reason.
Yeah. And funding must be the ability to obtain grants and such.
The rich get richer and the poor get poorer.
Okay. I know you were instrumental in getting the primary spine practitioner program going, the PSP program at UPitt. Do you do teaching in that, or are you basically, you got it running and now leave it up to the others to manage it?
No, I got it up and running. It's the director of that program now is Mike Timko, who's a physical therapist here.
Yeah.
But I'm involved with all the courses. I'm just not the director of it anymore. That's not my primary role.
Okay.
But
Good.
my hand's very deep in it.
Yeah. We'll be engaging, I'm sure, with Mike and Chris Buys and Marcia Spoto and Don Murphy again, to all faculty members in the program, get them
Yes.
engaged here with this. That's wonderful. Well, here's if we can, Mike, what I'd like to see if we could do is embark on a bit of a discussion. We're trying to frame the discussion around HEDIS measures, the healthcare effectiveness and information data set that are pertinent to people in spine care. So there are several of the measures that are really relevant. And the importance of something like HEDIS is 90% of the health plans in the United States use HEDIS measures. So they're extremely relevant to anybody in clinical practice if you're going to be going for any kind of recognition or accreditation. So the ones that are most important to us are imaging, physical activity in elderly, and if we have time, we'll talk a little bit about opiates. And I would like to save a few minutes for you to tell us a little bit about your current research. So let's start with what may be the most obvious, but sometimes most challenging topic, and that's imaging and spine pain. And we all know from research studies by Camper, by Maffei, that there's a lot of guideline discordant care in back pain. And one of the most notable guideline discordant practices is how often and how early imaging studies are ordered. I don't know specifically the breakdown between plain film, CT, and MR, but I know MR is an extremely costly imaging study and has been grossly overutilized. Certainly, Maffei's studies have borne that out. His initial one in 2013 and his follow-up one in 2021. We also know that imaging within the chiropractic profession is for back pain is contentious to a certain extent. You all remember the choosing wisely fights and arguments, and if we can, we'll maybe even get in a little bit to that. Physical therapists typically don't order imaging, but I would imagine were they to be ordering imaging on a more broad basis, they'd be facing the same challenges. So, given largely the overutilization of imaging in back pain, what I'd like you to talk a bit about is why is it such a challenge? And I should preface it by saying the HEDIS measure is the percentage of 18 to 50-year-olds who do not have an imaging study in the first 28 days of an episode of back pain, mechanical back pain, where there are no red flags. So that's basically the HEDIS measure, which is also basically the choosing wisely measure. So the higher that number, the better. What's your take on why it's been such a challenge, this notion of imaging and back pain?
Well, so first of all, we have data. We did a large observational study of 77 primary care clinics around the United States in our target trial. So we have data from our clinics that were involved in that trial, which was just a couple of years ago. And at that time, about 25% of patients were getting an X-ray or MRI within 21 days, within the first 3 weeks. 25%.
Wow. Okay.
It's pretty high.
Yeah.
Right? Which is pretty high. And there's been a lot done with qualitative interviews and focus groups of primary care physicians. They're the ones who are seeing most of the new patients, right?
Yeah, you
right?
bet.
And they're imaging people, and they've asked them why, and they say, well, especially when the guidelines say don't do it. right? Unless there's a red flag,
Yeah.
they're doing it anyway, mainly for two reasons. One is they think it's going to protect them medical legally. You order a test, right? It's the CYA principle.
Sure.
And the other one, believe it or not, is patient demand. What?
Yeah.
You're not going to get an X-ray? You're not getting an MRI? How do you know what's wrong with my back?
Yeah.
So rather than argue with them, they just order it.
Yeah.
And I think those are the two reasons in
Yeah.
primary care.
Yeah. Did you do any preface work with the clinics prior to looking at their utilization of imaging for back pain? I mean, you didn't go in and do any kind of an educational program with them or hand them a list of what current guidelines for imaging and back pain are?
Yeah, the clinics were given the ACP guidelines, which are pretty straightforward.
Yeah.
Whether they really, it's pretty obvious they don't. They might read them but not adhere to them. That's new. But no, there wasn't a specific training. Our trial was really aimed at getting them to early referral to physical therapy rather than treating them themselves.
And did you lead with that? I mean, that tell them that the purpose here is to say, look, if you have a patient with back pain, you're not quite sure what to do, rather than imaging, send them over to a physical therapist?
It was more than that. It was more than that. It was that this was a cluster randomized trial. So the primary care clinics were randomized, not the patients.
Okay.
Right?
Okay.
So I'll round it off. Let's say we had 80 primary care clinics. 40 of them were the intervention group, which was, hey guys, if we're going to give all of your patients this thing called the start back. If they're medium or high risk on the start back, you're going to get a pop-up window on your electronic medical record and just hit, it's going to say this patient in your clinic, remember you're the intervention clinic, early physical therapy.
Okay.
This window pops up, just hit yes, and it'll automatically generate the referral.
Wow.
Don't do anything else. Just get them, let the PT manage them. And if they're not getting well in a timely manner, they'll get back to you.
Yeah. 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 Now, did you see a big utilization difference between those intervention clinics and the clinics the controls?
Well, this was the interesting thing. So how hard is it for you to just click on a button that appears on your screen?
Not at all. It's not difficult at all.
How about less than 50% of the time did they agree to the referral?
Wow.
Completely teed up for them. All they do is say yes.
Yeah.
Less than 50% of the time.
Wow. Wow. Which shows you how incredibly challenging behavior change is in clinical practice.
Absolutely.
Yeah. Wow. Wow. Wow.
And then, of those who actually got the referral, only half of those patients actually went to the PT appointment. There's a lot of reasons for that, right? Co-pays, I'm going to get better. I don't want to try it, whatever. So if you think about it, that trial was kind of a null trial because of the low adherence to the protocol.
Right.
So if they can't even push a button to make an early referral of PT, it's much easier just to order that X-ray. And by the way, about 20% of them were getting an opioid within the first 3 weeks.
Oh my goodness.
This is 2 years ago.
Oh my goodness. When the opioid crisis was already well established and people knew there were constraints on use of opioids.
And what's really interesting, we looked at the clinics, remember 77 clinics. So on average, 20% of their patients getting an opioid. We had some clinics where it was like 2%. One clinic was 78% of their patients were getting an opioid. Wow. So the wide variability that we talk about existing in PT and Chiro, we want to talk about wide variability. Look at primary care in the prescription of opioids for back pain. It's all over the place.
Yeah. I know they've shown this in thresholds for who's going to get spine surgery, that a big determinant was where you trained, right? Where the threshold for who should get spine surgery at that residency program would often determine the way the clinician actually practiced wherever they moved to. And that's why, on variation, the Dartmouth variation curves for spine surgery, you see this place out in all the plain states out west where there's double the number of spine surgeries. It's because that's how they train them out there. Do you think that's a big influencer with PCPs, or do you think it goes back more to the cover your butt and demand?
If I had to pick one reason why primary care docs don't follow low back pain guidelines, it's because they don't think it's a problem.
Yeah.
Right? It's not life-threatening. In their opinion, patients with acute back pain are going to get better no matter what you do. So why do anything? Right?
Mhm.
And if they're not getting better, then you do everything.
Yeah.
Right? So either they're going to get better with nothing. If they're not getting better, give them an opioid, get an X-ray, get an MRI, send them to a specialist, do all this stuff. And then if surgery is not indicated, then maybe you'll try physical therapy or chiropractic.
Yeah,
It's
absolutely.
backwards, but it's the ignorance about the burden of back pain. It's
Truly.
not considered seriously.
And they look upon imaging as an innocuous procedure, right? That it doesn't lead to additional downstream costs and problems. And
We know that it does, right?
Yeah, absolutely.
Yeah.
Absolutely.
And patients now, look at their records, and when they see that MRI report, it scares them,
Yeah.
right? If somebody's
Truly.
already a fearful person to begin with and catastrophizes, when they read an MRI report, right?
Yeah.
And they see degenerative changes, blah, blah, herniation, bulging discs, some of these things which are normal aging processes, they don't have somebody to contextualize it for them, and it makes it worse. And they seek more care, and it leads to not just more downstream costs, but I think more suffering by patients.
Yeah. Let's ask your opinion a little bit about this idea of implementation in the field. I know you've done some work in implementation science, because this is an implementation issue, right? It's not, I mean, you couldn't have made it any easier for the PCPs to do the right thing.
Well, here's the interesting thing. If you look at the most recent study done by Jonathan Hill in the UK, these are the folks who developed the Start Back.
Start Back.
Yeah. By the way, I have to shout out there to Jeff Schur in the UK, because he's on this call. I see his name there. Hi, Jeff.
Hey, Jeff.
But
yeah, hi, Mike. It's nice to hear you. Nice to see you.
So that study that was recently done, like last year and the year before, was essentially what we did. They replicated. They took which is now the musculoskeletal, instead of the Start Back, it's the Start MSK.
Mm-hmm.
And they randomized primary care clinics, or GP clinics in UK, as they call them. And they had the same problem. They were randomized into two groups, cluster randomization. One group, early referral to PTs who had the training, right? And the other group, usual care. And less than 50% of the time, the primary care docs made that referral that they were supposed to do 100% of the time.
Yeah.
And they had a null trial for the same reason. They just can't follow what they're told to do. It's amazing.
Yeah.
And that was a huge trial, almost as large as ours. So now you have two large trials coming up with the same thing, which is that primary care docs, general practitioners, just can't seem to follow low back guidelines or even research protocols. So isn't it time to do something else, like this whole primary spine provider idea? PTs and chiro should be seeing these patients.
Absolutely.
Not primary care.
And we got to convince the plans. Did you, just out of curiosity, I don't even know if you broke it down to this level of granularity, did you see any difference between the physician extenders, the nurse practitioners and physician assistants, and the physicians, DO and MD?
We did not get that granular, but we actually submitted a grant this past year that did not get funded, where we proposed something novel, which would be, let's teach the PAs and nurse practitioners about the guidelines and let them manage back pain rather than the physicians.
Yeah.
And we have buy-in from our physicians about that, by the way.
Yeah.
They said, yeah, I'd be happy to shift this task over to my assistants, let them do it.
Yeah, they may be more amenable to that than directly referring out of their center.
Well, yeah, our hypothesis is, to your point, our hypothesis is that a physician assistant is used to being, they're like a soldier that follows out the general's orders.
Yeah.
And if we give them the orders, which are, here's the guidelines for back pain, right? You don't order opioids, you don't order imaging, and you don't send them to specialists. Instead, if there's no red flags, just send them to a PT or chiro. Which one? Ask the patients what their preference is.
Yeah,
That's simple.
sure.
If they do, and we think that they would follow those simple guidelines better than the physicians they work for. But we haven't
Okay.
been able to test that yet.
Okay.
Now, some malcontents would say, why do you expect them to do anything different than the people they work for?
Yeah.
They're in the same environment. They're going to act the same way. I don't know. We need, I think it's a hypothesis worthy of testing. And I think we're going to do that here at UPMC.
Okay. Brian Justice may have some data from the Blue Cross Blue Shield plan. He's with that, has actually gotten that granular. I've got to ask him about that. If they've looked at imaging ordering based on whether it's DOMD versus a PA or NP, but I'll get into that. Yeah. Thanks. That's
So
really,
getting back
I
to your
didn't
question, you asked a question about implementation.
yeah.
Be a little more specific about that.
Yeah, just overcoming the barriers to changing behavior, and education, maybe shifting over, the things you just mentioned, shifting over to PA and NPs, so that when a patient calls a primary care office, if their chief complaint is back pain, they're automatically booked with the PA or NP.
So I think that this isn't necessarily behavior change on the part of the provider only. What you're talking about is a workflow change, right?
Yeah, truly, ultimately.
People have proposed that to take this out of the hands of the discretion of the physician, and they push back about that in every case. If you were trying to automate those referrals, you would have huge pushback. And people have tried that in various healthcare systems. We tried that here. The reason we had to have that opt-in button on the screen was because we were just going to completely automate it, right? You're in the intervention clinic. If this person's medium or high risk, it'll generate a referral for physical therapy automatically. Okay with you? No, I have to make sure there's no red flags.
Yeah.
And they had all these excuses. And what it boiled down to was we were challenging their authority and their decision.
Yeah. Control.
They want that control.
Yeah.
But they showed that they couldn't live up to it 50% of the time.
Yeah. Gosh, that's dramatic.
So in
finding.
the implementation science world, they say that when you pop up windows like this for clinical decision supports, there's been research on this. They say that you get better compliance when you have an opt-out function rather than an opt-in.
So it's a sense of control.
Which we tried to do, but they wouldn't do it. So it could have been, here's the pop-up window. It's going to create an automatic referral unless you say no. The way we had it was, here's a pop-up window. Do you agree to that referral?
Okay.
Those are two different things that seem simple.
Yeah.
But in the implementation science world, it's the choice is a little bit different and it makes a difference in compliance.
Yeah. 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 Control seems to be a big, and I'm sure this issue of vicarious liability is a big issue. If the patient goes somewhere else, am I still liable for what happens to them because I sent them?
So we teach this in our PSP course, but plain X-ray is a very poor screening tool for pathology.
Terrible.
But yet a lot of chiropractors still will do that. I'll say, why do you take an X-ray on, all of your patients or half your patients? Well, 20 years ago, I found a patient with an ivory lumbar vertebra and they had prostate cancer.
Yeah.
Well, that's great. How many times has that happened to you? How many times have you had a normal X-ray where they turned out to have prostate cancer because you couldn't see it?
Yeah.
Right. So it's a very poor screening, has low sensitivity, right? When it's negative, you can't trust that it's negative.
Right.
And so primary care docs still think that. We've asked them, why do you take an X-ray? Well, I got to do something. Well, what did it tell you? Nothing.
Yeah. Yeah. And again, as you said, very often people do pull up that red herring that they saw 5 years ago and
in
justify.
In the implementation science world, they'll say that education alone never changes behavior. So if you have online modules, people they watch them, they check off the box, and they go back to do what they normally do.
Right.
Unless that education is followed up right? With some additional accountability. I think what's changed primary care, you talk about HEDIS measures, our physicians' reimbursement is tied to following, for example, diabetes management metrics,
Right.
right? They follow them, they get paid more. If they violate them, they get paid less.
Yeah. That's probably what it's going to take.
That's what changes behavior.
Yeah. Yeah. That's probably, I'm even getting providers to take the training very often requires a financial incentive. Just, even though there'll be a regression back to the mean and they're going to end up doing what they always do, just to get them to the table often takes a financial incentive. Yeah. Let's jump topics for a little bit. And I'd like to just very briefly ask you about this issue of physical activity in older adults, because it's actually a HEDIS measure. And I don't think chiropractors and physical therapists have that big a deal addressing it, but it's poorly addressed in the primary care world.
Yes.
The HEDIS scores were like 50%, meaning only 50% of the practices were talking with their patients over the age of 65 about physical activity levels. And so, any ideas or suggestions about how that can be more broadly implemented as an important quality metric?
Well, I think, so let's talk about two levels, one at the primary care level and then at the PT Chiro level, right?
Yeah.
So at the primary care level, I think it's like back pain. They don't think physical activity is a big deal.
Yeah.
Right? Unless they really see it as important, really, truly important to the patient's health, they're not going to have much interest in it. I think PTs and chiros, on the other hand, have great interest in physical activity in older adults.
Mhm.
As you know, I've done work in the area of lumbar spinal stenosis and will continue to do that. I work with physical therapists who've done research in knee and hip osteoarthritis. So if you take those three, those are the three big musculoskeletal conditions in older adults, right?
Yeah.
Hip OA, knee OA, lumbar spine OA, which is essentially stenosis, right?
Right.
So what we're finding now is it's the old chiropractic concept of maintenance care, supportive care. If a person has any of these three conditions, why would you expect a 6-week course bolus of care to cure? It's not going to cure them.
Sure.
It gets them on track. And this idea of bringing them back periodically for what, I like this word, physical therapists use the term booster sessions.
Oh, nice. That's better than maintenance.
Isn't it?
Yeah. Yeah.
Right.
Because it implies a more active approach, right? Maintenance sounds passive.
And so I think what you're going to see here, PTs and chiros are going to start using more of these apps that are out there, right? There are physical activity apps that people can use to track their activity, and they can be accountable for that, right? So if they're texting or using an app to text their PT or chiro once a week, hey, how many steps did you do this week, right? Did you do your walks, whatever? And then they bring them in for these booster sessions to reinforce the importance of physical activity. That's where I think PTs and chiros are going to play a huge role in this area of the managing what they call the silver tsunami, right?
You bet. I'm right in the middle of it, as you are.
Too. I am.
I have more of the silver than you do, though. You've maintained.
Yeah, I have highlights for being in the sun. But seriously, the management of older adults, right? The world is aging.
Yeah.
A quarter of the US population is going to be over the age of 60 here pretty soon.
Right.
Right? Japan, same thing. People are living longer, and the longer they live, the more likely they are to have these chronic musculoskeletal conditions that are not really amenable to medical treatment very well, right?
Right. There
Other
is
than joint replacement.
Yeah.
But if you're not going to have a joint replacement, what are you going to do? Just eat Motrin all day long?
Yeah.
Right?
Sure.
So I think we have a big role to play. And remember, lumbar spinal stenosis is the #1 reason for spine surgery in the Medicare population.
Yeah.
Right?
Yes.
And now with the emergent evidence coming out that epidural injection is not as good as people thought it was,
Right.
What are the alternatives?
Yeah.
And physical activity is so important in all of these conditions.
Yeah, absolutely. Yeah. Do you have specific, I mean, coming from the health and rehabilitation science program, how specific do you think exercise protocol need to be for an individual versus, is one much better than the other? Is one exercise approach much better than the other? Or is it more important to just get moving?
Well, it depends. For back pain, the literature out there. So I was a co-author on the recent American Physical Therapy Association clinical practice guideline, right? And there was a multiple systematic reviews done on every type of exercise that's out there. Motor control exercises, McKenzie exercises, aerobic exercise, strength and conditioning exercise. They all seem to be effective, right?
Yeah.
None has been shown to be superior to any other. However, it's like a lot of things, right? It fails to take into account subgrouping.
Yeah.
So is there a subgroup of patients that are going to do much better with strength and conditioning? I believe so. Is there a subgroup that would do better with motor control exercise? Now we're talking for back pain. Yes, I think there is. So we haven't done that kind of research to know what type of exercise for what type of patient. That needs to be done. As far as general health, I think general activity is more important than any specific activity. For example, if you're diabetic or have heart disease and you're not physically active, right?
Your
risk
in
of
trouble.
dying goes up.
Yeah.
And you would think that primary care would know this and push it, but they don't. So again, one of the side benefits of patients being treated for chronic musculoskeletal disorders by a chiro or PT, one of the side benefits is it's going to help their other comorbid medical conditions.
Totally.
Peripheral vascular disease, diabetes, heart disease issues, right? All those things will be benefited by regular activity that's prescribed and pushed by the PT or chiro, primarily for musculoskeletal, but it will help their general health on top of that.
Yeah.
This is where the use of health coaches is starting to become a big issue, a big adjunct here, at least in some of our clinics. I don't know worldwide if that's taking off, but in our physical therapy clinics now, when a person's done with their PT clinic, in addition to a booster session here or there, they often turn that patient over to a health coach.
Okay. Via an app or actually a live person?
A live person.
Okay. Yeah, that's a great idea. That's a great idea. Yeah, I'm familiar with some research actually that looked at the progression of comorbidities, diabetes, cardiovascular disease and such, relative to someone who's going through an elderly person going through an episode of musculoskeletal problems, where it actually exacerbates the comorbid condition because of inactivity. Yeah. So it is amazing to me that the HEDIS scores on this were so low, given the benefit of activity and movement for all those other diseases. Yeah. We know diabetes definitely does better when someone is exercising and active. Same with cardiovascular. That's wonderful. Before we jump to Q&A, some questions and answers, David Payton, can I call you in here for a moment?
Indeed. Thank you, John. Thank you,
Good.
Mike.
And he's just going to tell us a little bit about PSPN for just a few minutes. And then Mike will, if you're okay, will use the last 10 minutes for question and answer.
Sure.
Great. Thank you. We've already got a couple of Q&A questions in the actual Zoom chat. So John, you can stage those.
Okay.
And this will just be about 3 minutes long, and we'll jump straight into those immediately after this. So we just wanted to quickly cover what is the PSPN. This is this event that you're on is part of the PSPN, and it's the Primary Spine Provider Network is essentially a membership community platform that equips you as primary spine care practitioners with the tools, resources, and skills to advance your reputation and career. So we want you to become the provider of choice for high quality conservative spine care in your community, and thus increase referrals and improve patient outcomes. So some of the features includes a 3-hour online spine pathway workshop, monthly group coaching, which we kind of relabeled as virtual grand rounds. So essentially it's going to be a combination of group coaching, webinars, and case studies in which you'll be in this type of format and you'll be able to interact with the speakers. The Spine Pathway Workshop is a 3-hour program that is essentially a flyover of the broad concepts of primary spine care. Very comprehensive, evidence-based. Some of the benefits, of course, we've just mentioned, but one key aspect is that we donate $1 of each membership to World Spine Care, which is, as most of you will know, an organization that is bringing high-quality spine care to underserved regions. So for the price of a coffee every month, $8 a month, sign up today and give the gift of spine care to underserved communities while advancing your own skills, reputation, and career. With that, I'll add that link in the chat and we can go straight back to John.
Great. I'm just going to read a couple of the 2 comments and then I'll throw the question over to you, Mike. The first comment was this doc's experience is that most physicians, regardless of profession, think that they already know how to treat a patient more than, a computer recommendation or an app. And the second comment is support for this idea of subgrouping, but echoed your sentiment that we really haven't figured out scientifically how best to subgroup patients here. The question actually is related to imaging. Which guideline imaging recommendations would you tell this group to utilize? Any specific?
Not really. I mean, it's pretty simple.
They all say the same.
It's a red flag. The only reason to take an X-ray, in my opinion, is you're looking for fracture, right? Osteoporotic or traumatic. Other than that, an X-ray is really not necessary. And really a trial of care for anything makes sense. And if you're going to look for anything in the spine, MRI is the way to go now, right? I mean, no, there's no specific guideline I'd recommend. Everybody on this call probably knows when not to order imaging.
Yeah, they all say this same thing. By the way, in this Choosing Wisely program, there are 7 professional organizations, cross medicine, chiropractic, physical therapy, that all include imaging recommendations. And they all say exactly the same thing. And they all say just what we told you that the HEDIS measure was, which is in the first 4 weeks, don't order imaging. So thank you, Doug, for your comments. And thank you, James, for that question. There's another question here from Thomas. Let's see. Even though in the research, endurance versus MDT, which I believe is McKenzie, versus stabilization versus graded exposure, no real difference is shown. Is there a symptom response that should be analyzed as an outcome to dictate the correct exercise?
Yeah, we're back to the subgrouping thing, right? So
yeah,
if somebody has an acute antalgic lean and pain shooting down their leg, are we going to do endurance exercise with them? If they show a directional preference and centralization, then they should be getting that type of exercise. So I think matching, we don't have the research clinical trials to tell us, but I think most PTs and chiros understand this idea of subgrouping and matching their presentation. Graded exposure and exercise are more applicable to a person with really high fear avoidance of movement.
Yeah.
And anxiety. That patient does very well with graded activity. But a stoic Navy SEAL, why would you use graded exercise with them? Right? I think a lot of this is common sense for the PSP trained PTs and chiros.
Yeah. I do want to open it up to the panelists on the call, the 10 of you. If anybody has a question, you want to unmute yourself and ask that question, please jump right in.
John, Mike, can you hear me?
Yeah.
Austin McMillan. So appreciate the
Hey, Austin.
information. This might be a question that may be a little bit more appropriate for John. I'm not sure, but given the fact that there's so much difficulty in changing practice behavior with primary care, what have you found to be some of the most effective steps in trying to open up better relationships between a PSP and primary care to really move the needle toward utilizing PSP in back care, spine care, or even more generally musculoskeletal care? What really works?
Yeah, thanks. Great question, Austin. I'll just give you our brief experience and let Mike take a stab at this also. What we found is, we call it 7 touches. You have to assume you're going to have to reach out at least 7 times before they're probably going to listen to you. It's really about building trust, and it's in developing a common lexicon. So you got to speak their language. You have to use language that's not profession centric, idiocentric to what you do, but understand what they know and understand. And then, as Mike has already alluded to, you got to, help them solve a problem. What's the challenge or the issue with them? And then just be persistent. Any suggestions you have, Mike?
Yeah, there's no secret sauce here, right?
No.
Yeah, when I was in practice, I had a few primary care docs that I developed that personal relationship with, and they trusted me. The way I got my foot in the door is to say, look, let's just call it what it is. You have patients that are going to want to see a chiropractor, or you have patients that are going to want to see a physical therapist. And the reason they don't like to make a referral to PT or chiro is interesting. The variability. That's what they tell us.
Mm-hmm.
Our physicians here at UPMC, less than 20% of the time do they make a referral to physical therapy. Less than 20% of the time. And they own the clinics. Yeah. And when I ask them why they don't do that, well, I don't want to give them a blanket prescription for PT because I don't know what they're going to get. But I know this guy Mike, or I know this Amy, and if I could send them to them, then I'll do it. So they have to trust that particular practitioner. And if you're that go-to person who you say to them, look, you got patients that are wanting to go to chiros. Do you want to just go to anybody, or you want them to come to me? All right. Mm-hmm. I went through this PSP program at Pitt. I'm not wacky. And you know what? All you need is 1 or 2 to say yes, and you're set, because they'll send you so many patients.
Can I make a comment in regards to that?
Sure. Hi, Gilda.
Hi. Thank you for this. This is really great. Thank you, Dr. Mike. The PSP program changed how I practice, and I really enjoy it, and I really, really appreciate what you taught me. But going back into that, what I found is very effective is, as a chiropractor, when I write reports for the referrals, if I get referral through the HMO management system that I'm part of, when I write a good report for the primary care, then the likelihood they will refer patients more to me is higher than if you just don't even if they see you in person and talk to you. Writing reports seems to be very effective methods. That's been my.
Yeah, it's a form of communication, right? We talk to people, we Zoom, we text, but those reports is a reflection of who you are as a practitioner. And I think that's brilliant, right? That in your written word, you're communicating who you are to them. Now, I'll tell you really a controversial one. I'll just throw it on the table. This fear of stroke from cervical manipulation, whether we like it or not, it's out there. Mm-hmm. And I had one primary care doc, all he had to hear was that I said I was teaching, myofascial work, and, I'd taken some courses with Travell. Well, it turns out this primary care doc's father was a dentist who trained under Travell and did TMJ work. So he called me up and he said, oh, you do myofascial work? He goes, yeah. Well, so if I have a neck pain patient, you won't necessarily manipulate their neck? No, not if you don't want me to. And then people said, oh, you're selling out the profession, blah, blah, blah. It's like, really? Really? If that's what he wants and I do what he wants, he's going to send me patients? I mean, do I have to manipulate somebody's neck? Do I absolutely have to do that? No, I don't have to. And so that opened up a 25-year relationship with that one primary care doc. Just by me not insisting on doing it my way and working with him.
That's
I mean, that's one little area. And I think that's important too, right? That you come across as a team player and not the, lone wolf.
Mhm.
And that comes
Yeah.
across in reports as well. I would suspect, Gildy, right? In your report, you just lay out what you're doing in very sort of objective terms, and you're not getting emotional about it, not insisting that they have something, but it
Absolutely.
makes sense.
Absolutely. In regards to what you were just mentioning, I was part of a research group a couple of years ago through Monarch Healthcare, that's in South Orange County. And they picked a couple of chiropractors in their groups. They wanted to run a low back management strategy. And there was a neurosurgeon, a neurologist, a couple of chiros. They had to screen the chiros to be part of it. They wanted to utilize chiropractic care for basically managing a spine. And the neurologist was very, very sensitive to cervical spine adjustments. And he was just not having it. He's like, I don't like it. It's just, so we had to play, that. And in reality is like, I do not adjust everybody. I have patients whose brother just got diagnosed with arterial disorder. I'm like, well, if it's in the family, maybe you're at high risk. Why would I put myself and hers at risk? So that's the reality of practice, right?
It is. Absolutely. Yeah. Thank you, Gilda. Thanks very much.
I think something else we could say about the stroke issue, and I've mentioned this to a few doctors, it's been very effective, is that the large study that we all have heard that shows that the relationship between stroke and manipulation is not a causative, but an associated risk. And that we're the only profession that probably does the 4-minute neurological exam when the patient comes in to see if they're having a stroke. So more strokes happen when people leave medical doctors than leave chiropractors, but no one says that writing a prescription caused a stroke. But the person was having a stroke when they went in, and that wasn't spotted. So if we do a 4-minute screen or neurological screen, then we can pick out those patients who are at risk. And we're certainly not going to manipulate those patients.
Yeah, that's a good point.
Yeah, it's the temporal, in looking at case studies, it's the temporal relationship that kind of hangs us, is that it happens in such close proximity to when the adjustment was given. In those circumstances, science be damned, it's all about perception.
Well, this is a topic that's a whole nother hour discussion, right?
Yeah, we'll get into that. We've just hit our time, and I want to be very sensitive to Mike's time and everybody on this call's time, that we promised to quit at 1:15. We're already at 1:17. But Mike, as always, it's such a pleasure talking to you and learning from you. You're such a wealth of information, and we're all so grateful you're so willing to share it.
Yeah, anytime, John. If you want me back, I'm happy to do it.
Yeah, Warren, Mike Timko, and Chris, that will be coming back to them too.
Okay, I shall. All right,
All
take
right.
care, everyone.
Thank you, everybody. We really appreciate you, and we'll let you know when the next masterclass session will be, probably in March. Thanks again, everybody. Thank you, Mike.
Okay, bye-bye.
Bye now.